All right. So good morning, everyone. Um, so thanks for joining us for Cardiology Grand Rounds. I am so delighted to present Dr. Lee Harel-Sterling. So as most of you know, or all of you know, he's one of our PGY 6s in our adult cardiology program. He's also our chief resident, and Lee's going to be pursuing his critical care medicine fellowship in BC starting in July. So he's going to be presenting on long-term outcomes in cardiogenic shock, I think a topic very near and dear to his heart. And just to remind everyone who's in person, if you don't mind signing the sign-up sheet at the back, that would be much appreciated. So with that being said, I'll hand it over to Lee.
Thank you so much, Dr. Matthew, and for the kind introduction. And as she had mentioned, my hope today was to talk about kind of a personal topic of particular personal and professional and research interest of mine, which is long-term outcomes from cardiogenic shock and in general, or more generally, survivorship after cardiac critical illness. And I was hoping today to talk about some of the gaps that we've identified in the literature over the last few years and some of the work that I've been privileged to be a part of to try to address some of these research gaps. I have no disclosures for this talk. And I wanted to start off by talking about a real case of a patient I took care of in my C1 year when I was first starting here at the Heart Institute. I've changed some of the details to maintain patient confidentiality, but in brief, he was a 54-year-old man who was transferred here from a peripheral hospital for ongoing management of cardiogenic shock and for consideration of advanced therapies. He had minimal past medical history, and he had come to hospital after having a late presenting anterolateral STEMI and had immediate PCI to proximal LAD. But unfortunately, his course was complicated by significant mixed shock, and he was transferred extremely hemodynamically unstable for ongoing workup and management. He had a very complicated course in CCU, and I took care of him during one of my first CCU months. He was assessed by the advanced heart failure team, and unfortunately, due to multiple infections, predominantly vasoplegic shock and ongoing multi-organ failure, he was felt not to be a candidate for LVAD or heart transplant. And throughout his near 4-month-long admission to CCU, he had numerous complications, both cardiac and extracardiac. He was left despite revascularization with severe LV dysfunction, with severe mitral regurgitation, at one point needing stabilization with an intra-aortic balloon pump along with multiple pressors, and eventually getting a salvage mitral clip. He had a pulseless monomorphic VT arrest, eventually requiring a secondary prevention ICD, multiple episodes of atrial flutter and atrial fibrillation requiring cardioversion, multiple episodes of line sepsis with profound hemodynamic instability, nosocomial COVID, and ended up getting intubated in context of that and his severe MR, eventually requiring a tracheostomy. He had an anuric AKI. He had severe GI bleeds requiring multiple therapeutic endoscopies. He had provoked DVTs, and he had flaccid quadriplegia due to his severe critical illness polyneuropathy. And outside of ICU-acquired delirium, he essentially had every possible complication of his critical illness throughout his course. But through the truly heroic efforts of the team taking care of him, essentially every nurse that was working in the CCU, every single cardiology resident, and the staff attending in the unit, as well as our allied health team, he actually did have a remarkable recovery and improvement in his trajectory after his salvage clip. He ended up having full renal recovery. He was weaned off of the ventilator and decannulated from his tracheostomy. He rehabilitated with our allied health team, and at time of discharge from hospital was able to stand and starting to walk with minimal assistance. He was eventually transferred to the floor, transferred back to a peripheral hospital, and after a significant period of ongoing rehabilitation, was able to return home and to live independently with his family. And I really can't overemphasize the impact that this case had on me as a young trainee starting off in cardiology. It really solidified my early interest in cardiac critical care and convinced me that I should go on to do an ICU fellowship so I could learn how to take care of the sickest of the sick patients being admitted to our CCU. I wish this case had a happier outcome because unfortunately, several months after his discharge, closer to the 1-year mark near his infarct, this patient again redeveloped heart failure, presented to a peripheral hospital and worsened and redeveloped cardiogenic shock. and he ended up dying in hospital with the Heart Institute never being contacted. This was obviously extremely devastating for me as a trainee. I was very, very invested in this case. And it also challenged my understanding of what outcomes look like after cardiogenic shock. Now, here on this slide, I show a classic pathophysiological model of the downward spiral that occurs when patients develop AMI-associated cardiogenic shock, first outlined by Reynolds and colleagues in a classic Circulation Review article in 2008. And I had really taken to heart the idea that revascularization could stop this downward spiral and lead to survival with good quality of life. And we did see that initially with our patients after a period of stabilization. But I realized when I heard about his devastating outcome that I didn't have a good understanding of what long-term survival looked like once we hit this and what things look like after the fact. And it made me go back to the primary literature and try to understand better what data that we had to inform our patients and to better understand what long-term survival looked like after AMI-associated cardiogenic shock. The first place I went to was all the way back to the shock trial. Now, the shock trial is one of the most important studies that we have in the field of cardiac critical care. And the shock investigators, all the way back in 1999, randomized patients presenting with MI-associated cardiogenic shock to emergency revascularization versus immediate medical stabilization, showing a mortality benefit with emergency revasc. The same shock investigators later went on to continue following their patients out to 6 years and then to 10 years. And they published some of their long-term outcome data in JAMA in 2006. And despite a clear mortality difference in favor of early and emergency revascularization, long-term mortality was still substantial in this cohort. At 6 years, only 32% of patients who received emergency revascularization were alive. And there was substantial long-term mortality associated with this condition, even with optimal treatment with emergency revasc. And these findings were also reflected in long-term outcomes by Holger Thiel and colleagues in their long-term outcome study of the IVP Shock 2 trial, in which they compared usual care versus balloon pump in the treatment of MI-associated cardiogenic shock. They also found a 6-year mortality of roughly 67%. So these were two studies that seemed to suggest that there were poor prognosis in the long term after cardiogenic shock. But they were still relatively small and with a relatively small amount of people that were followed out to the 5, 6, 10-year mark. What other trial level data existed? Well, unfortunately, there was in fact very little. When we looked at other significant trials that have been published in the field of cardiogenic shock and MI-associated cardiogenic shock, we often talk about things like the culprit shock trial, the recently published ECLS shock trial, as well as DORE-ME. And in reality, these studies look very much at short-term outcomes rather than long-term outcomes after presentation with MI-associated cardiogenic shock. Holger Thiel and colleagues looked at multi-vessel versus infarct-related PCI in the culprit shock study, and they only looked at 1-year outcomes. They've not yet published their long-term data. In DORE-ME, the primary outcome of interest was in-hospital mortality, and we have no other long-term data available to us from that cohort. And in the recently published ECLS shock study, in which patients were randomized to either VA ECMO versus usual care, the outcome of interest was 30-day mortality. And again, we don't have any long-term data available to us yet from these studies. Hopefully in the future, but not today, to inform our practice and to help understand what patient trajectories look like. So I then went on to try to understand what things looked like and whether there was further data available from the observational literature. And unfortunately, there was actually even less data available to us from the published observational literature regarding long-term outcomes of MI-associated cardiogenic shock. Here is shown one of the most significant studies previously published in the field in a study published in Critical Care in 2014, where a group of French researchers compared patients presenting with MI with no shock versus MI with shock and plotted their long-term outcomes. And they did show increased mortality associated with MI and cardiogenic shock. But if you look here, in total, they're actually only able to identify 99 patients with MI-associated cardiogenic shock versus 3,300 patients with MI and no cardiogenic shock. Too few number of patients with shock to be able to draw any meaningful conclusions regarding their long-term outcomes and what survivorship looked like in this important patient population. I came to the conclusion that we had actually identified a significant gap in the literature and that we didn't have a good understanding and a good body of evidence to be able to base our recommendations for patients and to base our understanding of what long-term survival looked like after presentation with MI-associated cardiogenic shock. And that led us to try to fill that research gap. We did that by pairing with some scientists who work at ICS, formerly known as the Institute for Clinical and Evaluative Scientists. In particular, we worked with Dr. Shannon Fernando, who's an intensivist and a graduate of the Ottawa ICU program, and Dr. Peter Tanisopestro, who is a clinician scientist at UOH. The two of them previously had worked together and formed a research program called Lotus ICU, standing for long-term outcomes in survivors of critical illness. We paired with them along with the Capital Lab here at the Heart Institute to form a new collaboration and a new arm of this research program entitled Lotus CS, which stood for long-term outcomes in survivors of cardiogenic shock secondary to acute myocardial infarction. We had a number of research aims when we embarked on this project. The first two really related to what long-term mortality looked like and to further explore that using a series of population-level cohort studies. We first wanted to define what long-term mortality looked like from a larger population of cardiogenic shock patients. And two, we wanted to assess temporal trends in the incidence and mortality associated with acute myocardial infarction associated cardiogenic shock, or AMICS. We were able to do this because ICS holds a number of databases which are able to be linked together, which contains important information regarding every single person who lives in the province of Ontario, which is a total population of 14.6 million patients. Every single piece of medical care in the inpatient and outpatient setting, if billed through OHIP, ends up being cataloged and can be accessed at ICS with proper data clearance. And to be able to create these larger cohort studies and to be able to assess long-term outcomes and not just the inpatient mortality and shorter-term outcomes. This work ultimately ended up culminating in a publication that I was very privileged to be a part of as co-first author in the Journal of the American College of Cardiology earlier this year. I want to highlight a number of our collaborators. We worked, as I said, with Dr. Shan Fernando, with Dr. Peter Tanisopestro, but we also brought together a large group of content experts in cardiogenic shock, in cardiac critical illness, and in long-term survival from ICU in general to be able to create this work and to put it together. I really can't thank them enough for the mentorship that went into this project and helping me see it through to fruition. In terms of what we did, we first had to define a cohort of patients with AMICS. We did this by using the following 4 inclusion criteria. We first identified patients who had a diagnosis of MI. And thankfully, this has been previously shown to be possible using ICS data by looking at discharge diagnoses for acute myocardial infarction using the International Classification of Disease 9 and 10 diagnostic codes at time of hospital discharge. In the prior study by Austin and colleagues published in the American Heart Journal 2002, they're able to show that these discharge codes were highly sensitive and highly specific with greater than 95% sensitivity and specificity for identifying patients who were admitted to hospital with an MI. We then had to identify patients who had cardiogenic shock. We did that by trying to identify patients who were, 1, admitted to an ICU, and 2, had their ICU admission linked to a particular registry housed at ICS called CCIS, or the Critical Care Information System. We did this because CCIS holds key information regarding the treatments that patients receive in hospital, and they also hold key information regarding the degree of end organ hypoperfusion and end organ dysfunction that we would expect to see in patients presenting with cardiogenic shock. So we needed to identify patients who had a discharge diagnosis of AMI, who were admitted to an ICU as one would expect if one had cardiogenic shock, who were treated with a vasoactive agent, either a pressor or an inotrope, in keeping with guideline-directed medical management for cardiogenic shock, and the evidence of end organ dysfunction. And the end organ dysfunction was tabulated using a multi-organ dysfunction score, which was a previously validated method for assessing organ system variables and the degree of multi-organ failure in patients admitted to ICUs in the province of Ontario. It was actually created by researchers at the University of Toronto back in the 1990s and is validated and created using ICS data. And as you can see here, the MOD score can range from 0 to 24, with 24 reflecting higher degrees of critical illness and higher levels of ICU mortality approaching 100% as one reached a score of 24. To quantify end organ dysfunction, we chose a MOD score greater than or equal to 2 to represent our cohort. In total, we were able to identify, using this method, initially 366,136 patients who had a discharge diagnosis of acute myocardial infarction from April 2009 to March 2019. We then were able to identify 95,000 patients who had an ICU admission that was linked to CCIS. And after excluding patients who did not receive vasoactive agents or did not have end organ dysfunction, we were able to identify a cohort of 9,789 patients with AMI-associated cardiogenic shock who were admitted to 135 different centers across the province of Ontario over a 10-year span, representing the largest cohort to date of AMI-CS patients with long-term outcomes available to them and the ability to track long-term mortality and other important patient-centered outcomes. With all of this, we were able to calculate an overall incidence of AMI-CS at the population level, which we estimated to be 8.2 cases per 100,000 person years. We were also able to estimate that cardiogenic shock complicated 5.2% of all acute myocardial infarctions in the province of Ontario, which was in keeping with prior observational literature regarding the instance of cardiogenic shock after presentation with an MI. Here I show our baseline characteristics from our study. We subdivided patients. We first showed the total cohort, and we further subdivided patients into both survivors and non-survivors. And we collected important demographic data, both in terms of age and sex, but also social demographics such as income quintile and place of residence, whether they lived at home independently, home with home care, presenting from a long-term care, but also their past medical history, which we were able to do using other diagnostic codes. And wherever possible, we used diagnostic codes that have been previously validated in ICS registries and have been shown to be sensitive and specific for these particular past medical histories that we were interested in obtaining, so that we could understand what the total burden of kind of comorbidities were in our patient population. And so this again, took a lot of work, but we were able to have a population that seemed to reflect other previously published data sets of patients presenting with AMI-associated cardiogenic shock. We went on to look at their admission characteristics, again, dividing patients into the total cohort, survivors, and non-survivors. And this, again, was in keeping with other published cohorts of cardiogenic shock patients. In particular, the rates of invasive mechanical ventilation. Over 55% of our patients were ventilated at some point during their hospital stay. Total ICU length of stay also was in keeping with other published studies. In fact, a median ICU length of stay of 5 days, which I'm not sure if it appears well enough on the screen, but it was a median score of 5 days here, was identical to the ICU length of stay in the DORE-ME study and in culprit shock. And the rates of mechanical circulatory support that we found in our cohorts of 15% also matched the rates of MCS use published and shown in the DORE-ME study, which was a local study published here at the Heart Institute. And so we felt that our cohorts accurately represented a group of patients who had presented with AMI-associated cardiogenic shock across the province of Ontario. One statistic that did particularly stand out to us and that we did not initially have a good explanation for was the overall rates of coronary angiography and rates of early coronary angiography. In our cohort, only 70% of patients who had a discharge diagnosis of an MI complicated by cardiogenic shock actually had a coronary angiogram during their admission, which we were initially extremely surprised by. But when we went back to look at other observational data sets, we found that this was actually in keeping with previously published rates of coronary angiography in AMI-associated cardiogenic shock. Here was an elegant study published in Circulation Heart Failure in 2020, looking at location and time varying rates of coronary angiography using the national inpatient sample in the United States. They were able to capture all admissions for AMI-associated cardiogenic shock across the US, and were able to at least track in-hospital mortality, and also had access to rates of coronary angiograms during the index hospitalization. Although rates of coronary angiography improved over time, they in the end plateaued somewhere between 70 to 80%, even up to 2016, which were identical to the rates that we had found in our cohort. And again, made us convinced that we had correctly identified a cohort of AMI-CS patients. And it really highlighted as well the variabilities in care that patients received as they presented to different centers. And I'll remind you that we had patients being admitted to 135 different hospitals across the province of Ontario, where in the current date, there are only 25 to 30 hospitals who have cath labs that are able to immediately take patients. And so the majority of patients may actually present to hospitals without cath labs, and critical care transport, even in 2023, it can be extremely, extremely challenging. And so this really does highlight the variation in care that can occur as patients present to multiple different locations with various levels of critical care support and different levels of cardiology resources available to them. We then went on to look at what long-term survival looked like for our patients. Our primary outcome of interest was in-hospital mortality, but we also aimed to look at 30-day, 1-year, 2-year, and 5-year mortality. And for a subset of patients, we were actually able to follow out to 10-year mortality. And we ended up plotting this along a survival curve, which I've shown here. In total, 30% of patients in our cohort died during their index hospital stay. And at 1 year, 40% of patients had died, and at 5 years, 58.9% of patients had died. As you can see here, we were also able to follow a subset of patients from 5 years out to 10 years, and we could see that mortality continues to increase over time and does not ever truly plateau, but continues on this steady downward slope as time goes on. We attempted to look at prognostic factors associated with increased rates of in-hospital and 1-year mortality, which I show here. Factors associated with in-hospital mortality, as one would expect, included increasing age and the presence of STEMI. Patients who had presented and were initially admitted from long-term care also had higher short and long-term mortality. And interestingly, and perhaps somewhat frustratingly, patients who were in the lowest income quintile had higher rates of death compared to patients who were in the highest income quintile across the province, both for in-hospital and 1-year mortality. We also looked at what factors during an ICU admission factored into short and long-term mortality. As one would expect, the greater the degree of critical illness, the worse patients did. And so higher MODS at time of ICU admission was associated with increased rates of in-hospital and 1-year mortality. And the more number of life support interventions that patients required, whether renal replacement therapy, mechanical circulatory support, and invasive mechanical ventilation, as well as prolonged duration of vasoactive medications such as pressors or inotropes, were all associated with increased in-hospital mortality, and the majority of them also associated with increased 1-year mortality. Really highlighting that the sicker that patients are in hospital, the worse that they do in the long term. We then moved on to try to address objective number 2, which was to look at temporal trends in how, in the instance of cardiogenic shock and in short and long-term mortality. We did this by plotting the overall incidence and mortality associated with each case by fiscal year, comparing to the total number of patients living in Ontario per year that we had studied. And so we looked at patients initially presenting in 2009 to 2010 and went by fiscal year up until 2018, 2019. We showed an increase in incidence of AMI-CS over time, beginning at 8.07 cases per 100,000 person years in 2008, 2009, going up to 9.58 cases per 100,000 person years in the 2018, 2019 fiscal year for a p-value of 0.003. We also looked at changes in in-hospital 1-year mortality. And while these were statistically significant reductions, they did not quite meet criteria for clinical significant improvement. Relative declines in hospital mortality were there at a statistical level. In hospital mortality in 2008, 2009 was 30%, but it was 28.9% in 2018, 2019 for a 1% absolute reduction in hospital mortality across 10 years in the province. 1-year mortality was similarly poor, 41% in 2009, going down to 38.3% in 2019, for a roughly 3% absolute reduction in 1-year mortality, despite 10 years of work in this field across the province. We also looked at other factors and to see if there's any temporal association between some other interventions that patients received. Interestingly, rates of mechanical circulatory support did not change in our study over time. The vast majority of patients, when they went on to MCS, had a balloon pump placed. A small minority of patients were candidate for VA ECMO or had Impella. And interestingly, despite the publication of the IVP SHOCK 2 trial, which showed no improvement in mortality with the routine use of intra-aortic balloon pumps in AMI-associated cardiogenic shock, and the publication of that in 2011, 2012, there was in fact no change in rates of balloon pump usage across the province of Ontario across the 10 following years. Which again is interesting and hypothesis generating, but is just one piece of the puzzle. We didn't want to just stop there, and we didn't want to just focus on long-term mortality, because we realized that there are other significant outcomes beyond just in-hospital long-term mortality that mattered to patients, and that we wanted to capture because it was not previously described in this cohort of AMI-CS survivors. So we wanted to look at quality of life, and we wanted to look at patient-centered outcomes. Here I show some of the best data that we have that actually comes from a follow-up study done by the shock investigators all the way back in 1999. And the shock investigators went on to assess patients at 2 weeks post-discharge, 6 months, and 1 year with a number of telephone interviews. And they asked patients to quantify their symptoms and graded them in terms of their NYHA functional class. They also asked patients to assess their own quality of life and rate it on a nominal scale going from 0 to 10, where 0 represents the worst possible quality of life, essentially being hopeless, and 10 represents the best possible quality of life, being prospering. Here you can see on the graph in white, in the patients who had emergency revascularization or ERV, the majority of patients seem to have NYHA functional class 1 to 2 symptoms at 2 weeks, 6 months, and 1 year. And in the patients who had emergency revascularization, they on average rated their own quality of life and their own health status as being 7 out of 10 at the 1 year mark, significantly improved from patients who had the initial medical stabilization. But this was essentially some of the only patient-centered outcome data and health-reported quality of life data that we had in this important patient population, with very little other work in terms of long-term outcomes after AMI-associated cardiogenic shock. The outcome of this and the message that seemed to come out of it was, to improve quality of life after cardiogenic shock, we should revascularize more, and that seemed to improve patient outcomes. But we wanted to look at what patient outcomes truly look like at a population level using our data set. Now, we weren't able to capture NYHA functional class symptoms because we did not have direct access to patient data. We didn't have some of that more granular data, but we did try to look at other important patient outcomes, and specifically outcomes that have been previously deemed to be important by patients when interviewed during and after an ICU stay. Patients admitted to ICU and after discharge highlight rates of readmission to hospital. They highlight the number of days that they are able to spend at home, not living in on a ward or in a rehab institution, not going to medical appointments or in the emergency department, as particularly valuable to them. They also value that change in functional status and change in living situation as an important outcome from their critical illness. And these were important patient-centered outcomes that we were able to capture with our LOTUS CS dataset. And here we are able to show them kind of in table format. At time of discharge, roughly half of patients were able to be discharged home without home care, but roughly 1/3 required increased home care at home. Another 12% were discharged to a rehab facility. And in total, 42% of patients had a change in their baseline disposition at time of discharge from hospital. We also looked at readmission rates, and readmission rates were unfortunately extremely high in our cohort. At 30 days, 19% of patients were readmitted to hospital. At 1 year, 47.5% of patients were readmitted to hospital. And in terms of time spent at home, uh, of the 365 days after discharge from hospital for an index hospitalization with AMI-associated cardiogenic shock, on average, patients spent only 307 of those days living at home, and the other close to 60 days either readmitted to hospital at medical appointments in rehabilitation. A significant impairment on quality of life. And I show all of this also in kind of a more a figure format highlighting the time varying patient outcomes in the first year after discharge and even after survival from cardiogenic shock. As you can see here, only roughly 25% of patients highlighted in this top graph in blue were at 1 year living at home, not readmitted to hospital, not having a change in their baseline disposition. The other roughly 75% of patients had either unfortunately died at 1 year, had been readmitted to hospital, or had a change in their baseline functional status and had a change in their living situation after being admitted with AMI-associated cardiogenic shock, highlighting the severe morbidity and mortality associated with this condition and the ongoing work that needs to be done to try to improve patient outcomes, even after discharge from hospital. But I also recognize that we couldn't just rely on administrative data to tell the patient story here. And although we had very important data that we were able to collect with the LOTUS CS registry, we also needed to get more granular data and to understand what the patient experience looked like as patients presented, went through their hospital stay, and went home after being admitted with cardiogenic shock. And to a greater degree, also what it looked like for being admitted to a CCU in general and survivorship after cardiac critical illness. And to understand what survivorship after cardiac critical illness looks like, I need to take a small segue to talk about the subfield of ICU related to ICU survivorship. Much of this work has been championed by a number of researchers, both in the United States, in France, but also here in Canada, and particularly at the Toronto General Hospital with Margaret Herridge. And Dr. Herridge, along with Ali Azoulay, in a very, very good review article published in the New England Journal of Medicine earlier this year, talked about the spectrum of recovery that came after admission to critical illness. They identified kind of three patient trajectories. The first patient, patient A, had very good pre-morbid functional status and quality of life, had a temporary worsening during their initial ICU admission, but eventually improved. And they will improve almost essentially regardless of what we do, although they never quite return to their pre-morbid quality of life and functional status. Another subset of patients had poor baseline functional status or severe illness, and unfortunately died during their initial ICU admission. And the third subset of patients had, a medium amount of functional disabilities, a moderate amount of impairment in quality of life, and have a severe drop in quality of life during their ICU admission and never return to baseline to anywhere the same amount that patient A does. The ongoing research is being done to try to figure out what can be done at the time of ICU admission to reduce degrees of iatrogenesis and decrease this total drop in quality of life and functional status that occurs during ICU, and also to improve long-term outcomes to hopefully move this curve from here to here. Dr. Herridge and her colleagues have outlined a number of issues that are being faced by survivors of critical illness, patients in ICU, but also their loved ones, family, children, and caregivers all face issues when they survive their ICU stay. And Dr. Harridge has worked very hard to outline the entire spectrum of issues that patients face, both physical conditions, mental, and psychological issues that are faced in survivors of critical illness. And the culmination of all of these symptoms together come together to form something that's called the post-intensive care syndrome, or PICS. And recognizing that there's also significant impairment on quality of life, significant psychological distress, that can come to witnesses to critical illness and to family members, there's also a separate disorder called PICS family, or PICS F, which recognizes the secondary moral injury that can occur to family members and to survivors of critical illness. This has been very well described in a number and by following patients in ICU and then following them after discharge from ICU in specialty ICU recovery clinics, such as those exist at the University of Toronto and a number of centers across the United States and in Europe. But how does this relate to survivorship after cardiac critical illness and recovery after CICU? Well, the truth is we don't know at the time of this presentation how it relates, because we can only study what we measure and what we ask patients about. We can only understand the patient journey and their recovery process if we take the time to understand what the patient experiences is during their time in a cardiac intensive care unit and after being discharged. And while quality of life after ICU discharge has been well studied, quality of life after admission to CICU remains unknown. And we can't know where patients are going until we understand where they've been and what the patient experience is. And there's reasons to believe that our cardiac patients might have a different trajectory than patients admitted to a general medical or surgical ICU. They have different comorbidities. They may or may not be more awake and have lower rates of mechanical ventilation and less amounts of sedation. They have increasing pill burden and other issues when they leave the hospital, separate from other general medical or surgical patients. Wanted to briefly highlight some of the studies that have been done kind of in the realm of ICU survivorship, looking at health-related quality of life and patient-reported quality of life. This was a study done by Dr. Cuthbertson and all out of the University of Toronto, looking at patient-reported quality of life out to 5 years after discharge from an ICU. But they followed patients predominantly admitted to a series of medical surgical ICUs with high rates of trauma and surgical admissions, very low rates of cardiac patients. And this data is not really applicable to our patients. What about important functional limitations after admission to ICU? Well, some very important work has been done, but only a minority or none of the patients followed in some of these groundbreaking important studies in the fields of ICU survivorship have followed cardiac patients. Dr. Harridge has a rather famous cohort of patients with severe acute respiratory distress syndrome that she's followed out to 5 and now close to 10 years and looked at functional outcomes after survivorship from critical illness. But they only looked at ARDS and non-cardiogenic pulmonary edema. There's been several other studies by a group out in Vanderbilt looking at cognitive disability after admission to ICU, and they used a mixed ICU cohort, but only 17% of their patients were admitted with either cardiogenic shock, MIs, or significant arrhythmias. And so it's very difficult to draw conclusions from these studies as to what functional outcomes look like for our cardiac patients, what cognitive outcomes look like for our cardiac patients, and what health-reported quality of life looks like for our long-term survivals after cardiac critical illness. In my mind, the solution for this is to have special clinics to be able to follow these patients. And just as the ICU world has created ICU recovery clinics, to create CICU recovery clinics to be able to better understand the patient trajectory after recovery from cardiac critical illness. And I was inspired by this, in particular by a case report that had been published in JACC Case Reports, describing the creation of a resident-led CICU recovery clinic in the University of Kentucky. This group later went on to publish in 2022 their first results from the first 42 patients that they had followed in the first 52 weeks of this clinic since its inception. And seeing that such a thing was possible, that a resident-led clinic could be created, I went on to approach Dr. Froschel in my PGY5 here and Dr. Matthew, and to see about creating a resident-led clinic here at the Ottawa Heart Institute to similarly look at patient outcomes after cardiac critical illness. And with Dr. Froschel's gracious permission and with mentorship by Dr. Matthew, we went on to create a cardiac intensive care ambulatory recovery clinic here at the Heart Institute. And I've had the privilege to follow patients in this clinic throughout the last year and a half, and to try to better understand what the patient experience is after discharge from CICU, and to try to understand what patient-centered outcomes look like after discharge from cardiac critical illness and survivorship. Here I show just some of our inclusion criteria. We arbitrarily, after consulting with a few other physicians who work in the field of ICU survivorship, picked an arbitrary date of greater than 7 days of total ICU length of stay, as identified with weekly screening, and would invite said patients for voluntary or optional follow-up in our clinic in parallel with any other cardiology follow-up that they may have, to dedicate specific time to talk about their patient experience during their CICU stay and after discharge from hospital. We also try to set out specific objectives to act as a safety net for high-risk patients, to determine what patient-reported quality of life look like at time of discharge and in follow-up, and to better understand the patient experience. Now, I don't have data from this clinic to share with you yet today because we're still in the process of putting this together. This is an ongoing project that I hope to share the results of in the coming months to years. But I did want to share some of the outcome measures that we're looking at. We are trying to look at patient-reported quality of life using the San Francisco 36 questionnaire, which is a very well validated and well-published method to look at patient-reported quality of life. And we're trying to objectively assess patient functional outcomes using the 6-minute walk test. And although I don't have objective data to share with you at the time of this presentation, I did want to highlight some of the experiences that patients have shared with me during their follow-up with me in clinic, because I think it's important for us to hear what the patient experience is like after being discharged from ICU. And the patients I've seen are incredibly grateful for the care that they've provided. They're incredibly happy that they have survived this significant medical illness. But they also report significant psychological, physical, and mental trauma associated with their stay. These are just some of the quotes that patients have talked to me about in terms of what their lived experience is like in the cardiac intensive care unit. The first thing that many patients remember is not actually coming to hospital. It's being woken up in bed, feeling like they're surrounded by strange figures, feeling like they're being attacked or that people are trying to kill them or to murder them. People remember feeling shackled to their bed and thinking that they are in prison and mistaking their support apparatus, including their PA catheters, their central line, their Foley catheters, and their breathing tubes, as shackles chaining them to a prison. And patients report significant quality of life impairment and significant traumatic memories, even talking about PTSD, and being so afraid to relive that same experience that they wake up at night in tears. I wanted to highlight these patient experiences because we need to understand this to have a good understanding of what we're trying to prevent and how we can better serve our patients, both at time of their CCU stay and after their discharge from hospital, and even after they improve over time. What does that patient experience look like? So we've talked about a lot of different things today, and I want to just summarize a few key points from this presentation. So one, the instance of acute myocardial infarction associated cardiogenic shock continues to increase over time with minimal change in both short and long-term mortality over time. The long-term mortality from AMI-CS remains poor. Among AMI-CS survivors, there are high rates of readmission to hospital and evidence of poor functional status based off of population-level data in the province of Ontario. Patient-reported quality of life and survivorship is an important field and something that we need to pay attention to in the growing subspecialty of cardiac critical care. and is something that I hope to spend a significant amount of time to in the next few years to try to better understand what the patient experience is like. In terms of future directions, well, there are multiple. There is, the question of what the long-term prognosis is after non-AMI associated cardiogenic shock, because as a reminder, we only looked at AMI associated cardiogenic shock. We need to try to assess what potentially modifiable risk factors are to try to improve long-term mortality and morbidity for our patients. We need to better understand what the actual total prevalence of PICS is in our patient population and understand the total burden that it causes patients in terms of quality adjusted life years. And we need to try to identify ways that we can improve care at time of index admission in the cardiac intensive care unit to reduce the long-term incidence of PICS. In terms of LOTUS CS, we already have a number of other projects that we are working towards, and these are just three that we are trying to move towards publication in the coming months. Dr. Shannon Fernando is looking in particular about mental health outcomes in survivors of AMI-CS. Simon Parlow had put together a paper looking at healthcare utilization and costs at a provincial level with AMI-associated cardiogenic shock. And I'm currently putting together another paper looking at guideline-based therapy in survivors of cardiogenic shock and trying to better understand what the readmissions rates to hospital and causes of readmission are for this important patient population. I wanted to acknowledge the number of mentors that have supported me throughout this entire project and over the last 2.5 years. In particular, every single nurse that I've worked with in the CCU. Xandra Koopman, who's been instrumental in helping to found the CCU Recovery Clinic and helps us screen patients week by week. Bailey Morgan, who helps us with our 6-minute walk tests. To Dr. Froschel for his support to actually be able to go and found this recovery clinic in my C2 year. Dr. Ben Hibbert for helping support my initial work and the initial creation of the LOTUS CS dataset. Dr. Shannon Fernando and all of our co-investigators for LOTUS CS, and in particular, Dr. Rebecca Matthew, who's really supported me through every step of this process. I really can't thank everybody enough, and I'll open the floor to any questions. Okay.
That was remarkable, Lee. I mean, I'm particularly proud of you, but thank you for walking us through, I think, this not so well described and super important journey for our patients. So I think your career, as you look into this more, is going to be remarkable. I see Dr. Chi's hand up. I had a question, but please go ahead. Do you want me to bring you the? I think this. I'll repeat it, but we're supposed to use the mic, but go ahead.
Thank you. So Dr. Chi's question I'll try to paraphrase, but it relates to, what should be our accepted outcome measure in patients presenting with MI-associated cardiogenic shock, and also relates to are we able to predict which patients might do well in relation to that, if I'm paraphrasing somewhat correctly. And to be honest, I think it's a somewhat difficult question to answer because to a certain degree, we ask our patients and we rely on their preconceived wishes of what a good quality of life looks like in term to decide what a good outcome from their ICU stay might be. I think, from the perspective of what we should aim towards, I think not just looking at in-hospital mortality, but at minimum 1 year mortality and up to 2 or 5 year mortality is a very important metric to look at for our patients. In particular, because we recognize that many of our patients with MI-associated cardiogenic shock are going to be left with moderate to severe LV dysfunction, getting them to the point of being able to follow up in the outpatient setting and be up-titrated on GDMT to try to modulate their long-term survival is, I think, an important outcome beyond just in-hospital survival. In terms of the amount of resources that we put towards that, I shared an extreme case of that for the first patient I presented who was essentially admitted for 4 months to a cardiac intensive care unit, had enormous amounts of resources put into his care. It comes down to a much more of a philosophical, societal question as to how much resources are we willing to place on the society to take care of such critically ill patients. Because in the end, while he did have a poor outcome, he also did have an incredibly important last 6 months where he was living independently, cognitively intact with his family. I don't have the tools yet, and I don't have the larger answers to what is the amount of value that we place on that as a society in terms of those 6 months living independently at home. And in terms of trying to predict things in the future, that is some future work that we're looking to put together. I think putting together a risk score to be able to try to understand what the odds of long-term survival with good quality of life looks like after initial admission to MI-associated cardiogenic shock. So I think I have more questions than answers for your question, but it's something that we need to explore further because it's at the heart of why we're doing this work. Oh, I see. From Dr. David Burney and from Dr. Peter Liu. I see here from Dr. David Burney. I might just read it out.
So question, is it possible that some of these patients had non-ischemic cardiomyopathy with cardiogenic shock and type 2 MI due to limitation of administrative data?
Absolutely. And, in the end, we don't have access to patients' charts and the granular data regarding what happened during their hospital stay. We make inferences based off of the data that we're able to glean. But ideally, in the future, we might try to look at, are we able to further categorize patients into type of shock that they had and even severity of shock, such as classifying them to the SKY classification. This is not currently available data to us, but it's something that we would hope to try to do in the future with this data set. And I can't rule out that we captured some subset of patients who had non-AMI associated cardiogenic shock and type 2 MIs. Having said that, in our data set, we did mandate that the primary discharge diagnosis was MI, not heart failure or cardiogenic shock, which we felt increased the likelihood that we captured a primarily MI associated cardiogenic shock data set. But we can't know for sure because of the limitations of what we had.
So what are the modifiable risk factors in AMI-associated cardiogenic shock patients prior to presentation?
I hope to spend a career answering that question. Dr. Chan, I'm not sure yet. I think we're able to clearly identify patient factors that were associated with poor in-hospital and long-term mortality, including increasing age, increasing number of comorbidities, and increasing degrees of critical illness. But I think we are still working to try to find both pre-admission characteristics that are modifiable to reduce the incidence and severity of cardiogenic shock, and also interventions both during the initial CICU stay and at time of follow-up to reduce the future incidence of morbidity and mortality. And it does speak that I still don't fully understand from our data set what long-term morbidity and mortality is due to, and that's part of the ongoing work that we're doing. We don't actually know, are these patients dying of recurrent cardiogenic shock? Are they actually representing the hospital with non-cardiac illness and dying of non-cardiac disease? And that's part of the ongoing work that we're doing, and I think we need to gather that information first before we're able to clearly identify modifiable risk factors. I feel like we're still in the information gathering phase of kind of studying this patient population.
It's certainly still in infancy. We see that all the time, right? So it's such a great time to be young staff and researchers. Oh, I'm so sorry, Dr. Beanlands. I was looking at the screen. Okay. No. I think, Dr. Liu, I'm so sorry. Did you have your hand is up? And then Dr. Hibbert is second.
No worries. Oh, great to see Ben. But that's a fantastic presentation. I'm really impressed in terms of the data you have gathered, the insights you have developed, and of course the clinic is just exceptional. Kind of three things come to mind a bit. Relate to the questions raised earlier. One is that deeper dive on the data is really helpful, and so down the road, if you need help, we now have access to things like Ontario Health Data Platform and some of the deeper dive linked data, so happy to help on that side. But I do absolutely agree that, there probably is some heterogeneity in the population, the ability to actually decipher the risk profile for the patient and therefore be able to tailor the treatment strategies will be important. The other thing I wondered whether, sort of taking the lessons, from dealing with cardiac arrest, and then that, timing is important in terms of, addressing these conditions earlier, and whether there can be, system-based issues, in terms of, for example, getting the patient diagnosed earlier, recognized earlier in institute early treatment will be potentially important as a one thing, to think about it as a strategy. And the last thing I want to mention is, congratulate you in terms of looking at some of these patient-relevant outcomes. Of course, we're very much interested in the brain and the heart connection, which, includes, and I wonder whether there are probably changes in cerebral blood flow in terms of inflammatory changes, in the brain and other organs that can actually affect, both perception as well as cognition, but as well as the mental health impact, which you are exploring really nicely. And I think because there can be funding opportunities to develop this area, so definitely incorporate this in your onward journey. So again, congratulations.
Thank you so much for the comments, Dr. Liu. And I agree, there's so many interesting avenues that we are able to take this research. And I think one of the points you made in particular bears highlighting is that there are stark variabilities in the care that patients receive across the province. In particular, the only 70% rates of coronary angiography when your primary discharge diagnosis is MI, that we know that revascularization is the only thing that we have strong evidence that actually improves long-term survival for, clearly shows that there's a marked heterogeneity and the need to improve the way that we deliver care for our patients, even at the time of their initial hospital stay. And all the rest of that other work to really try to understand, and with multiple different methods, what survivorship and everything else looks like is very, very important.
I think Dr. Hibbert is joining us from Mayo, which is great. He's been a strong mentor for all of us.
Perfect. Can you guys hear me?
Yeah.
Excellent. So really great job, Lee. I know we've had a lot of chance to talk about this, and I agree with you. I think when we think about cardiogenic shock, for the longest time, we have thought about, how do we intervene during the acute phase of cardiogenic shock to improve mortality? And we've fallen down. Even the shock trials, technically a negative trial, we interpret it as a positive trial because secondary endpoints were positive, but even revascularization is negative in the acute phase of shock. And so I think we do have to start looking at kind of the pre-shock phase. Can we prevent shock from developing? I think that's a real opportunity for intervention in this population. And as you very nicely highlighted in this talk, post-survival might be a great place to bend the curve. That being said, you know, if
Hello,
you pie in the sky had the ability to do whatever you want, what
I'm
therapy
listening
would
to
you
a
test or
presentation
apply
on shock.
to improve outcomes following cardiogenic shock? And are you a little bit worried that it may recapitulate the inpatient studies where these patients have a very poor prognosis, but we're unable to bend that curve?
I mean, that is a real concern of mine. And I think, you know, if I could design a future research program, the future thing to look at in particular for these patients is to how to ultimately change that long-term downsloping in survival that we saw from our initial survival curve. Um, I do still, maybe I'm just an optimist, but I do want to believe that we have ways that we can shift that curve. But I think we need further information first to understand why these patients are suffering from morbidity and mortality. But if we look at some of the other ICU literature, looking at, you know, good parallel would be studies looking at weaning from mechanical ventilation. Enormous amount of initial work was initially being put into the hyperacute phase in patients who initially had presented with hypoxemic rest failure, and looking at initial ventilation strategies to try to improve long-term survival. And then researchers came on to realize that over 50% of time spent on a ventilator was actually spent in the weaning phase, and that essentially no research was being done to look at how we could improve patient experience as they weaned from a ventilator. I think that's a very important, you know, comparison to make with our literature. We've put in enormous amounts of resources to look at the hyperacute treatment for cardiogenic shock. We're now starting to look at ways to prevent shock and looking into the SCI-B population to try to prevent that worsening. But I think we also need to be putting in interventions first to understand what the long-term trajectory looks like, and then to try to see if we can recreate studies that might reduce long-term morbidity and mortality. No, the hope is, my personal hope is that a significant amount of morbidity and mortality is actually due to LV dysfunction, because we have excellent treatments available to that. If you look at a recently published study like the STRONG-HF trial, they randomized patients to usual care versus an intensive follow-up in clinic with rapid up titration of guideline-based medical therapy, and they showed improvement in survival and in outcomes with rapid up titration of GDMT. If we're able to actually identify this high-risk subset of populations of AMICS survivors, truly prove that they're actually having significant morbidity related to LV dysfunction rather than non-cardiac things, and be able to design a study to try to improve late survival in a similar way that we improve the weaning phase off of a ventilator, I think that's a very important avenue to explore for our patients, and something that I want to look forward to in the future.
Dr. Beelands?
What's the next bench that you want to look at? I think first, big congratulations on this is fantastic. And learning from sure that we can be and using that to kind of decision making and help us move patient care bigger and stronger. What I would encourage is in the opportunity that Dr. Lu mentioned, right, part to interconnect them. Portal being set up, not just our data, but looking into other data, because ours going to be in large amounts of data to help the size of the things. The other thing one of the points you made about the case was the patient came from follow-up. They never contacted the institute. So the other thing to potentially look at is how we get the message out to the general region to better make decisions. The bedside when you're coming to Cornwall or various or wherever you show up. And it was fantastic work. Congratulations. Hard to see them all.
Thank you so much, Dr. Beelands. Thanks so much, everyone.
Okay, I think we're past the hour. I mean, thank you again, Lee, and congratulations. Just a phenomenal body of work. I think we're all really excited to watch the trajectory of your career and super proud of you.
Thank you so much.
Okay.